I'm Karen Calhoun, as Tricia shared. I'm with our community engagement program. We have a process called Polls Everywhere, where I'm going to put it in the chat box, and you guys can click in, and we can create a little Wordle.
And it should work if you guys text a word how you feel about COVID-19 vaccine trials, and just be honest.
So if you text 37607, then put in the link as Tricia said, or put in the message. Patricia, oh, it's working. Folks are getting there.
Oh yeah, you see it?
I'm scared.
Karen, you see it?
I do.
You got it to work.
Okay, cool.
How do you do it again?
If you just click on that link, and then you can type in words.
Or Ella, if you text to the number 37607, then Patricia, PIEC 859, your word. And you can actually put more than one word, but.
Okay, and if I can't do all of that, click on what?
Click on the link in the chat box.
Oh, that makes.
I don't know how to do it.
I don't
know I'm not supposed to
bad.
these calls.
I will put, if you can't get it, we'll put your words that you in for you.
That's exactly what I was finna say. If they put them in the chat, then you type it in, that works.
Okay. So look at that, it works.
Yeah, I am definitely feeling technically challenged. My word was leery.
Okay.
I don't know.
Okay, just a couple more minutes.
No, couple more seconds.
Okay, a couple more seconds. Yeah, it may not work for you depending on your service plan too with the texting.
As the poll is full, so.
Okay, Karen, take us away. I think people it's
okay, cool. So I'm going to introduce Susan Wolford, who's a pediatrician and part of our community engagement faculty. And she's going to present some slides very briefly that, will help to educate us on vaccines. And she will also introduce our expert speaker. Susan?
Okay. Thank you so much, Karen.
Uh-oh.
Yeah, you muted.
Susan, are you with us?
Unmute. Yes, can you hear me now?
Yes.
Yes.
Can you hear me?
Yes.
Yeah.
Okay, wonderful. That was a work at home moment. I think my phone connected to another system. So thank you for this opportunity to share a little bit about the novel coronavirus and vaccines. So we're all sort of starting at the same place. Probably a good place to start is by discussing what a vaccine is, and so what a virus is. And as you might know, a virus is a tiny infectious particle that cannot live outside of another host for very long at all. And in the middle, it has this genetic material. And then on the outside, there's a fatty layer with protein markers. So these coronaviruses have been around for many years, but then more recently in 2019, we had the novel coronavirus that came along. These coronaviruses, you might wonder, where did they get their name? Well, they got it because somebody thought it looked like a crown, the corona, like around the sun. And when they looked at it under a microscope, they thought it looked that way. And so that's why they were called coronaviruses. So how do viruses work? Well, if we think about the cells in the body as a factory, and imagine that that factory has a job. Say the job is to make cars. But along comes a virus, and that virus hijacks the factory, stops it from making those cars, and starts making it create parts of itself. It destroys the cell and then puts those parts together to make more of itself. And the coronavirus is so dangerous because the cells it likes to take over are cells in the respiratory system, and it couldn't do it in other organs as well. But that's why we see a lot of respiratory symptoms when we have people who are infected by coronavirus. So how do we fight this and any other infection? Well, we have many systems, but I'd like to tell you about a few here. Phagocytes, which we might remember the word more easily if we think about Faygo, the very popular soda in this area. So phagocytes are cells that will come in when they find that there's an infection, and they will engulf and consume that infection, much like we might consume a Faygo soda, and it will kill it in that way. Then we have antibodies. And the way in that antibodies work is that when a virus is present or an infection is present, the antibodies, the B cells, will make the antibodies that will surround that infection and attract cells to come in and kill it. And then we have yet another type of cell called killer cells. And these cells, if you remember, I mentioned that viruses go in and get inside a cell. But some very clever cells are able to put antigens, put signals on the outside that say we're infected. That draws in these killer cells, and the killer cells do their job and kill that cell containing the virus. So that is how some of the cells in our immune system work. So what do immunizations do? Well, immunizations are self-defense training camp for our immune system. It trains them to recognize this particular virus so that when you get in contact with that virus, you're ready to fight that virus off. And that's me doing Taekwondo. Well, not very good at Taekwondo, but it's the same kind of training. You train ahead of time so that when you come in contact with the actual threat, you're able to fight it off. And we're very good with vaccines. As a pediatrician, I am all about good vaccines because we have vaccines for all of these illnesses that I have listed here. And many of these things we don't see anymore very much because the vaccines are so effective. I just want to highlight one of them. Meningitis, as many of you might know, is an infection of the lining around the brain. So you see here the normal brain and one that has been infected. And this is a graph that shows the prevalence of, or the number of infections by Haemophilus influenza that caused meningitis by year. And you'll see that there's an incredible drop-off over the years in the prevalence of this type of meningitis. And you will not be surprised to note that that drop-off first occurred when the vaccine became widely available. As the vaccine became available, we see that we practically see almost no cases of Haemophilus influenza meningitis anymore. So vaccines work really well. But within this setting now, knowing that vaccines work well, we're faced with the issue of a COVID-19 vaccine. And I'm sure that all of the discussion around vaccines and around COVID-19 have led to many of us on this call having many questions. And so we are going to hand over now to Dr. Call, a professor of infectious disease and internal medicine at the University of Michigan. And he is going to share with us a more detailed discussion of immunizations, vaccines, and trials, and including the disparities that we see in this arena. And then following his presentation, we'll have time for your questions. So please do put your questions into the chat, and we will be happy to answer those at the end of the presentation. So thank you so much, Dr. Call. Over to you.
Thank you. So far, and thanks everyone for coming. And I've already heard a whole bunch of interesting things in the breakout sessions and elsewhere. So hopefully I can give you a little bit of information about COVID in general, but really with a focus on the vaccines. I was looking really hard for at least one positive word that came up with that that kind of word salad or whatever you call those graphs of words. I think the best that we got was like doubtful, something like that. So hopefully people will feel a little bit more optimistic. And as I said in the breakout session, there really has been some pushback from both the FDA and from the pharmaceutical manufacturers at some of the attempts to kind of politicize this vaccine and get it out there before it's really ready. But just before I get into things, just a few words about myself, because I don't know too many of the folks on the call. But I'm an infectious disease doctor at the University of Michigan. I mostly focus on infectious complications that follow transplants, like kidney transplants and lung transplants and bone marrow transplants. But when COVID started, we all kind of had to get to learn about that and get going. And I've probably taken care of at least 100, 150 people and their families with COVID, and talked with many of these people, many of these patients and their families about different trials and treatments and so forth. And it's very clear that, you know, one of the best ways out of this is through medical research. So actually, could I just ask, I don't know if I want to share the screen or if someone can advance the slides. I don't think I can. Thank you. So what I'll cover is the current state of the pandemic, the racial and ethnic disparities in COVID, both who gets it, who gets sick with it, and who dies from it, which are, you know, incredibly striking. And I think mirror disparities in other areas of healthcare and in other aspects of things as well. I'll talk about the vaccine development and the many, many challenges, not least amongst which is a huge amount of mistrust. And finally, I'll talk a little bit about the current treatments. And everybody always asks about the things that they gave the president, so I'll mention that a little bit. And just the fact that we really have to do proper clinical trials if we're going to have any idea how to help people with COVID. So next slide. So current state of the pandemic, despite what you may hear, we are not winning at COVID. So, you know, the United States, I think, is about 4% of the world's population, but we have about 200,000, over 200,000 deaths in the United States, and there are clearly more than those that are not properly counted. So, you know, 20% of the world's deaths, 4% of the population, not doing so well. And when you look over at that panel on the right, as you look at the screen, these are just deaths per week by cause, and heart disease and cancer are always the two leading causes of death. And then out of nowhere came COVID, and you can see when it was really bad in New York and Detroit and some other large cities, you know, it was the leading cause of death in the United States. Now it's the third leading cause of death. As we've gotten a little bit better at treating it and hospitals aren't as overwhelmed, but anybody who says it's the flu or it's nothing or it's a hoax hasn't spent any time in the hospital or among communities that have been affected by it, or they just don't want to say the truth. When you look at the slide lower left, sadly, that's the number of cases. You can't really see the dates at the bottom, but the last date is October. And so the higher that little blue bar is, each one's essentially just a count of the number of cases. So that first bump over there where it's high, that was back in April. And then the number of cases really soared over the summer, came back down, and now it's probably going up. And most people think it may get higher than it ever was before. Hopefully that won't be accompanied by an equal increase in the number of deaths and serious illness, but it certainly may be. So we're by no means out of this or even close to it. Next slide. And then just hit the run one more time. Yeah. And so when you look at the racial disparities, actually, if you hit it one more time and then stop, that's all I've got on that one. Thanks. You can see that that if you look at cases, so who's getting COVID, that Black Americans are overrepresented in that group compared to the percent of the population. And then it gets worse if you look at it by death. That's the lower panel there. And then the panel to the right, which is just attempt to sort of normalize it or make it show by how much the death rate is compared to that portion of the population. And you can see, you know, there's a vast increase in the death rate among Black Americans compared to white Americans and Asian, Pacific Islander, and even Native Americans. So a huge increase there. Next slide. And I think there might be one in between. Isn't there one before that? Yeah, no, all right. I'm sorry, go ahead, yeah, next slide. And so this is just another way, this is a slide the CDC made, but you can see if you look at the fourth column over where it says Black or African-American non-Hispanic persons. So this is national data. The previous data I showed you was just from the state of Michigan. So you have a 2.6 higher rate of getting COVID. You got a 4.7, almost 5-fold higher rate of getting hospitalized if you get COVID. If you're Black or African-American non-Hispanic, and a 2-fold greater rate of dying from COVID. And if you look in the right-hand column, that's Hispanic or Latino persons who don't seem to have an increased death rate. And sometimes this can get skewed because if you're getting it in a lot younger population, you may have less death, but increased hospitalization, increased number of cases, and the same is true in American Indian or Alaska Native. Next slide, please. And why is this? So there's a whole bunch of reasons. There really isn't any evidence that there's some sort of, genetic difference in terms of susceptibility, but it's probably just part and parcel of sort of long-standing health and social inequities. So potentially more crowding, the kinds of employment that may expose you to an increased risk of COVID, and then due to all sorts of other factors and decreased access to healthcare services that lead to more comorbidities, and that then leads to, if you happen to get COVID, you have more illness and a greater risk of death associated with COVID. Next slide, please. So how do we get out of this mess that's a mess for everyone, but is particularly bad in certain communities? Well, it's really going to be more than one thing. There's going to be no, sort of magic bullet and all of a sudden, everything can go back to normal. We need to do more testing. We need that testing to be available for anybody who wants it, anytime they want it. We need it to be simple. There are these antigen tests, which look sort of like pregnancy tests. They're not as good as the PCR test, which you have to do in a lab. But, you could imagine a situation where, the way you could get school really going again is where every kid's taking the test 2-3 times a week. There are some universities that have employed these widely with some success. You have to still do masks and other things, but these can be produced very, 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 very cheaply. There is simple public health interventions like masks, which have been so sadly politicized. Now wearing a mask is sort of a signifier of all sorts of other political things that make no sense. And we see people standing on verandas ripping off masks to show that they're, that they're macho. And it's just terrible because they really can work and drive down the rates of infection and protect other people. It's just a good thing to do to protect both yourself and others. There are certain activities that are just really hard to do when you have COVID. And so this is a bar in East Lansing where Michigan State students were going over the summer, and it was one of the largest outbreaks in the country, hundreds of cases that all could have come from just one infected person. So when you go into a poorly ventilated space, like the basement of a bar, where the air isn't circulating, where nobody's wearing a mask, where people are talking loudly, they're gonna make COVID airborne in that circumstance. And one person who doesn't even have symptoms can give it to 100 or 200 other people, and then they may spread it. So those poorly ventilated spaces, indoor without masks, are a recipe for disaster. So we have to kind of limit those. I mean, just in the last, let's see, it was 2 weekends ago, I was working in the hospital and saw 2 patients, both who were not gonna survive, both who got these, in this case, from their wives who had gone, was in a bar, but weddings, other situations where there's just a bunch of people crowded together, and then a whole bunch of people get COVID and spread it further. There are treatments now that will help. And there's really a lot of promising treatments that are coming out to help get us out of this. And then finally, a vaccine. So it's all these things together that I think will help get us out of this. But it's certainly going to take some time. Next slide, please. So I will talk a little bit about how vaccines are developed. So first you do what are called phase 1 studies. So those are in relatively small numbers of people. This is the one that has really the highest risk to the volunteers, and volunteers in phase 1 studies are typically people who are quite healthy, and you do it in these small numbers. In this, it says 20 to 100 people, sometimes a little bit less, a little bit more, and you're really just looking for safety. And if things look good there, then you go on and you do phase 2, where you give it to often a few hundred, or for some of these vaccines, it's been more like 1,000 people. And you're trying to figure out, do people need 1 dose or 2 doses? Learn more about side effects. And what you measure here is, did at least somebody's immune system respond in a way that suggests that they'll be protected from infection? And in this case, many of the vaccine candidates look really, really good. So they did seem to give good immune responses and did seem to be safe. There was also tests done in chimpanzees to look to see, if you give it to chimpanzees, wait a month or 2, squirt COVID in their nose, do they get COVID? And in general, they didn't get any kind of severe COVID. So that's at least helpful too. Now many of the vaccines are in phase 3 trials, where you're giving it from 30 to 60,000 volunteers, and you give placebo or vaccine. Those of us on the study don't know what we're giving, and those receiving don't know what they're getting. And then you just look and see over a number of months who got COVID and did the vaccine protect people, and you also look at safety. Now, normally these 3 phases would take at least a decade, at least 10 years. And they're trying to do it in a year and a half or so. And, that's very, very fast. It doesn't mean it can't be done in that period of time, but it's much quicker than it ever was in the past. After those phase 3 studies are done, then the companies can submit to the FDA. And I'll talk about that in a little, because I think that's where there's a lot of mistrust right now. Next slide, please. And so I think the words that we saw people giving in terms of their thoughts about a vaccine are reflected in the population in the country as a whole. This was a survey that asked people, so would you definitely probably take a vaccine if one were available? So back in May, and part of this might be because people were more scared about COVID, maybe back then, at least some people, wasn't too low. But when you go to September and you ask the same question, it plummets. And for reasons I think that are very historically accurately based on race or ethnicity, you see different levels of trust. When they ask people further, what are you worried about? The biggest 2 were, well, I don't even know if it's going to work, so I don't trust it's going to work, so why would I take it? and then concern about side effects. And then some people who felt, well, I'm not really worried about COVID, I don't need it, and concerns about price. And I hope and pray, although I don't know, that this will be available to everyone without cost. But I actually, maybe I'm just optimistic. I think that will happen, but I also think that we haven't seen a lot of other parts of the healthcare system where anything's available without cost. So it's, I guess, kind of hold your breath on that. Next slide, please. This is a study I found that I thought was kind of interesting. That this is about influenza vaccine, but it asked adults of different races. It was sort of narrative, you know, asking people questions in a structured way. And most people, regardless of race, really didn't trust pharmaceutical companies and felt that they were profit motivated. And I think anybody, whether you're on the provider side or on the patient side, we all see that pharmaceutical companies are profit motivated. That doesn't mean they can't be motivated by other things, and that everything they do is necessarily, you know, unethical, but there's no question pharmaceutical companies are profit motivated. And then when you looked at government institutions, that might be the FDA or health departments, there was less trust among Black people. Next slide, please. And that was specifically related to COVID vaccines. And I think we're all familiar with the really horrible history of unethical medical trials, surgeries. I mean, the list just goes on and on people of color in the United States that leads to mistrust. I found this article pretty interesting. It was a community group in Pittsburgh who was going around and trying to encourage vaccine uptake in communities of color in their area. And I think they were largely motivated by the desire to include as many people of color as possible in vaccine trials, because if you don't include, you know, groups that are at highest risk, it's going to be hard to know if there are differences in efficacy between different groups. Next slide, please. In terms of where we are with the vaccine, worldwide, there are about 11 vaccines now that are in the latest or phase 3, where you can really start to get an idea about efficacy. In the US, I believe there are 4 right now, either 4 or 5, one of which is the Moderna one, which they were doing at Henry Ford, the Pfizer one. They weren't doing that at Henry Ford. The Pfizer one, which had already gotten past 30,000. That'll probably be the first one where we'll see some results as to whether it prevented COVID or not, as well as safety data. Next one, please. And then around vaccine implementation, there are just massive, massive challenges. So the Pfizer and Moderna vaccines, so those are the ones I just mentioned that are probably farthest along, they have to be frozen at -70 or -20 degrees. So how are you going to do that in a clinic, in a community health center? Very, very difficult. Some hospitals don't even have enough freezer space for that. So how is that going to be distributed? That has to be figured out now, how to get this out to people. There isn't going to be enough vaccine at first. And so there are various plans about what groups do you prioritize. So they sort of start with healthcare workers, and then people at higher risk, people who work in positions where they're put at greater risk of getting COVID, and then moving more into healthy people or healthier people. But even with that, you know, kind of plans which are being formulated, we even heard, you know, Senator Harris express a sentiment, which frankly, you know, I mean, I have to say I kind of share, which is that when you hear the White House saying, you know, we're going to get this out by election day, and you put it in context, you say, well, how do I know that's safe and effective if it's clearly being done to affect, you know, the political fortunes of the group of people that are in charge? And I think that's what Senator Harris was really kind of expressing. The good news that I can tell you is that so far the FDA has not buckled to that. Now, what would happen after an election, depending on who wins, I can't say, but they have not buckled to that pressure, and there's not going to be a vaccine approved before the election. The pharmaceutical companies have made a calculation that it's not in their interest to approve a vaccine that hasn't been properly tested, that will come back on them in a negative way. So those two groups kind of push back. And I think that very scary threat of having something approved that isn't even properly tested has receded. We'll see what happens after November 3rd, but I feel that it's receded for now. Next slide, please. And against all that horrible background, you know, I do want to mention that vaccines are probably one of the top 3, you know, things that have helped human health over the last, you know, well, since cowpox. And so these slides are all people with different diseases that, as an infectious disease doctor now for more than 20 years, all these diseases that hundreds of millions of people have suffered from, I've only ever seen one of these once, which is the guy on the right with the funny expression who has tetanus, which makes all his muscles contract. There's no good treatment for tetanus except keeping people alive and then letting it kind of go away over weeks. But nobody gets tetanus anymore because of vaccines. This child in the middle with these horrible bumps on him, that disease is a disease that's killed more people, you know, than anything else in history. That's smallpox. That's no longer around. No one has smallpox anymore because of a vaccine. The upper one is diphtheria, also gone pretty much, at least in the United States, because of a vaccine, which used to kill, you know, many children each year. And finally, even measles down below, we rarely see now. I mean, you do get some outbreaks because of vaccine. And even things like the flu vaccine, you can see in the upper left, you know, every year, this is for the 2019-20, prevented about 6,000 deaths, over 100,000 hospitalizations, and, you know, 7.5 million flu-like illnesses. So vaccines, when they're safe and properly tested, you know, are incredible tools for public health. Next slide, please. And this is, you know, the other good news is that we are coming up with more and more treatments, and they do make a big difference for a lot of patients. And they're either new drugs like this remdesivir, which we participated in a number of remdesivir trials. I probably talked to, like I said, over 100 patients and their families, sometimes for hours, over whether they wanted to get this particular drug. And there is enough of this. We can give this to everybody who has COVID, who needs it now in the hospital. Simple drugs like dexamethasone, which is kind of like prednisone that you might take for asthma. Please don't take it as an outpatient for COVID. It can make things worse, but in the proper circumstance, it can be life-saving. Unfortunately, it's very cheap. And then this picture over on the left of that funny gray and blue thing, that's the Regeneron antibody. These look extremely promising. This is what they gave Trump. And it's, in my view, having seen a lot of, you know, obese 74-year-old men with bad COVID like he had, they did not, they weren't out giving rallies in Florida a week later. So I think that's probably why, in combination with, he also got remdesivir, he also got dexamethasone, probably why he's better. So those are very, very, very promising treatments. There won't be enough of them for a while, but they can really prevent people. It looks like they may be able to prevent people if you get them to people early from even getting sick or needing to go to the ER or go to the hospital. I think that's it. Just last slide, maybe. Yeah, so thank you. And I know we were going to have some discussion time. It looks like there's a lot of questions as well.
Yes, there's a bunch of questions, and thank you so much, Dan and Susan. Those were fine presentations and beautiful slides. I'm going to start with a question that we received online. How can a statewide effort to address COVID-19 be representative of Michigan's population if diversity and inclusion do not recognize the needs of at-risk minorities and indigenous population? and indigenous population base. So Dan, there's a bunch of docs on our call. And I'm going to kind of call you guys out right quick, to be on call for questions. So Erica, Susan Wolford, Susan Gould, Tammy Chang, Diane Harper, Don Vereen, Richard Bryce. We want to share in this Q&A process. We have only about 10 minutes to keep it flowing for our next presentation. So Dan, how about if you kick us off? And again, the question is, how can a statewide effort addresses COVID-19 be representative of Michigan's population if diversity and inclusion do not recognize the needs of at-risk minorities and indigenous population base?
Well, gosh, I don't think it can. I mean, whatever the effort is, if it's a vaccine trial or a trial of any new treatment, it needs to represent the community as a whole. And, that's a huge challenge. If it's contact tracing, for example, which we talked about, because, there are countries that pretty much got rid of COVID, China, Taiwan, South Korea. That was mostly through identification and contact tracing, but you have to have a high level of trust, right? And so if it's not kind of culturally sensitive, people from the community doing the contact tracing, where people I think are going to be understandably suspicious, it's going to fail. I guess the list goes on and on of different interventions that have to be equitable and sensitive to those needs, or they aren't going to work. I think whoever posed the question is absolutely right.
Thank you so much. Go ahead.
No, go ahead, Susan.
Go ahead,
No. I was gonna, just so we can get through as many questions as possible, I was gonna suggest that we move on to the next question, but you go ahead. If you have something to add, go ahead, please.
Yeah, nope, I was about to move to the next question. So I was just gonna say, we have a lot of questions in the chat. And so I'm gonna put two together here. The question is, will the vaccine be a live or dead virus? And will the vaccine be safe for those who may have an impaired immune system?
Yeah, so there's, the answer is sort of both for the will it be live or dead. So there's no vaccine that is alive or attenuated, like a shortened SARS-CoV-2, which is the virus that causes COVID. There's no vaccine like that. Most of the vaccines don't have anything live in them. There's one that's pretty early that Merck is working on that is basically like the measles vaccine. And there's one that uses it's called vesicular stomatitis. It's a virus that in some animals can cause like mouth ulcers. So they shorten those viruses and use those. But in general, they're going to be not live vaccines. In terms of immunosuppressed people, it's a very tricky situation because none of these phase 3 trials will include immunosuppressed populations. Those will have to come later. And whether or not we'll be willing to recommend it for those populations without a lot of data and how well it will work in those populations, we're not going to know for a really long time. So that's just part of the complication of applying these. And that's why it's so important that people can take it, because then you can kind of drive COVID away and other folks who can't get the vaccine but are at risk may be protected.
Dan, I have a quick question. Will these vaccines be safe for pregnant patients?
It's another group. So in every clinical trial I've ever done, I've not been able to give anything to anyone pregnant, and you have to do like 11 pregnancy tests before it can even enter, and so we probably won't know for sure, and folks like yourself will have to think hard about how we're gonna apply that. So right now in the trials, you're not even supposed to it's a month apart for some of the trials if it's 2 doses. So you're supposed to sign that you're going to use birth control and so forth, and not plan on getting pregnant for at least a month after the second dose.
Dan, this is Ken Resnick. I'm curious, I've seen a little bit on this about people taking more than one type of vaccine. What is known about that, and do you see that actually happening?
Yeah, I suspect though people that will do that, it's not a good idea and not necessary, and no one will know if that's safe or not, because I don't think there'll be any studies that look at taking one vaccine and then another vaccine.
Question from the go ahead. Who's speaking?
I apologize. I should have raised my hand. Javonda, I was wondering, like, with these people taking these vaccines and they're not really being tested long enough, do you think that may have a lot to do with why maybe we're having a lot of our kids have issues, pregnant women may have tried it, not been pregnant before, but may have participated and come up with something later on down the line. And maybe that's why a lot of our kids may be having so many issues.
I mean, I think so. I mean, so I think you're not probably talking about COVID vaccines, because that, you know, they haven't gotten to that level yet. So, you know, the big one that came out that people were worried about was autism, and there was never any evidence for that. And there have been multiple studies that have shown
I just wanted to ask a question that been on my mind.
Oh, sure, absolutely.
Better to ask than somebody that I feel like I can talk to. I'm not making it an issue.
Oh yeah, no, I'm just trying to answer it honestly. My honest answer is that there isn't any, nobody's ever really been able to show an association between any, you know, childhood vaccine and things like autism. But I do appreciate the question.
I understand things just happen in life, but I just wanted to ask somebody.
No, and that's exactly why we have Dr. Call here today. So thank you. And that's what we want. He's here today because he is happy to answer questions from anybody who's attending the retreat. So I think the question that was just asked is a very common question, and a question that a lot of people have. And it's good to have, it's good to know that a lot of the hype around it is actually not based on, even though it's very out there in the news and in social media, based on what Dr. Call said, at least with autism, there's not data supporting that vaccines contribute to autism, which is reassuring to know.
Well, I wasn't talking about autism, but just anything in that region.
No, we understand.
Have different things.
Got it.
We're so glad you asked. We're so glad you asked that question. As a pediatrician, I get that question a lot in clinic, and so I'm really glad you raised it here, because it allows us to say that vaccines have been shown to be really safe. And so thank you so much for asking that one. And I'm glad you got it in, because we probably have time for just one more question before we close out. Karen, do you have the one last question we can take?
Yes. Will the vaccine slough off and be at risk to others you are around? That's a question from the chat.
No, it won't. So it doesn't have any like COVID virus in it that could ever infect anybody else.
I have one last question, actually. In terms of the trials, what are the primary side effects that folks are being seen in the trials, and that the people doing the trials are concerned about?
Yeah, so raise your hands if you've had a shingles vaccine. You don't have to, because that's medical, you know, information, but I'm raising my hand, and I didn't much enjoy it. So, you know, but I know shingles is worse. So you have to be old, you have to be older than 50. I'm speaking for myself here. So it's kind of like that. So it definitely causes, most of these vaccines so far do cause maybe a low-grade fever, some muscle aches, maybe a little bit of a flu-like illness in at least half the people that get them. The reason is that they're stimulating your immune system. That's what they're supposed to do. So your immune system thinks it has an infection. There's no actual infection there, but it thinks it is, and it's responding to it, and it's making antibodies and doing other things that hopefully would protect you. when you get it. But most vaccines don't make people feel sick, except maybe the sore shoulder. Most of these probably will.
Okay. All right.
Thank you so much. It looks like we're pretty much out of time. I would like to say there are lots of great responses in the chat and some wonderful links. Dr. Chang put a link to a JAMA article about why we might have more cases in the US and deaths in the US than in other places. And there are some other great links in the chat. So please look at those. And I would like to thank Dr. Cole so much for all the information he shared with us. We're going to have to move on to the next item now, but I think it's very clear that there are lots of questions around this topic. And I think I speak for CE when I say that maybe we will be doing more sessions that will allow us to answer questions. Dr. Marsh?
I'm trying to control. No, we're gonna have him back, but I'm trying to control myself. I'm gonna throw in one more question. Why is it important? Why can't we just have young, healthy white men try the vaccine? Like, why can't we just, why should I put myself at risk as a African American woman that may have some risk factors? Why can't I just have these young people who are healthy try the vaccine?
Yeah, another great question. So you need to make sure that the vaccines work in the population that's at risk. And so that's probably the biggest reason, because, if I'm counseling a patient, I want to be able to say confidently that it's been tested in people who are from your community, who are like you, and I'm confident that it works in that population. So that's probably the biggest reason. And that's obviously been a huge problem in medical research over the years, that it hasn't been representative of the population as a whole. And that's had major effects on giving people medicines that may work for another group but don't work for them.
I was just going to push back on that, Dan. This is Susan, because frankly, one of the reasons we have so much great research on coronary artery disease is because, it was the disease of well-off white men, and yet they applied the research to everybody else, not just well-off white men. So we've used research to make medical decisions when the research has not included a diverse population, or has not included them at the extent to which we have the ability to say, yes, it works in this subgroup.
Right, and sometimes it applies and sometimes it doesn't, right? So there are differences in beta blockers and calcium channel blockers and ACE inhibitors and things like that from one group to another. So yeah, I mean, maybe if you gave it to all white men and you saw less COVID, it would work in every group, but maybe not.
Thank you. I don't want to cut anyone off. I want to let everyone know.
I want to ask you more questions.
Oh, no, you can ask more questions, Dr. Marsh.
No. I'll leave Dan alone.
I just want to let you guys know that we are recording the chat too. So all your questions will help us kind of guide the work that of the SEAL project, which Dr. Marsh mentioned earlier. So just know that your comments, your questions, any feedback you have after today will go on to address, mistrust, misinformation, and the need for more education so that, people can make the right choice for them and their families. So, so stay tuned for more from us. Everybody who comes today will be part of our network. We'll add you if you're not already added, and you will hear next steps moving forward on this much needed work.